Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here at the AusACPDM conference in Cairns, Australia, to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based.
We are back in the Research Works booth at AusACademy,
Yes,
Australian AusACPDM. I keep getting the acronym wrong. We are joined this time by Associate Professor of Pediatrics at the University of Pennsylvania and faculty in the Division of Rehabilitation Medicine at the Children's Hospital of Philadelphia, Laura Prosser. Welcome.
Welcome.
Thank you. Thank you for having me, Dana and Ashley.
Look, I've been excited to speak to you for a long time. We caught up very briefly yesterday at the welcome reception and started talking instantly about a whole lot of things. So, anyway, tried to hold back, ask you lots of questions about it today.
Yes.
You are presenting several papers and they're both related, so we thought we'd try to put them both into one. Just for everyone listening, the first paper is titled Estimating the Difficulty Level of Motor Practice During Physical Therapy Sessions in Young Children with Cerebral Palsy, and the second being Motor Error During Physical Therapy in Young Children with Cerebral Palsy. Both very, very appealing titles.
Yes.
Anyway, do you want to ask the first question? Because otherwise I can feel myself hogging it already.
Yeah,
I'm
no,
so
that's
sorry.
okay. So, Laura, tell us a bit about what you set out to do with these papers. I'm really interested in this idea of quantifying difficulty.
Yep.
And obviously that ties into motor error. So how did you kind of
Yeah, sure.
come about this?
So we've undertaken a pretty extensive effort over the last several years to try to describe in great detail the motor experiences of young children during their with CP during their rehabilitation therapy sessions. And so we measure lots of different variables. I'm going to in this afternoon session share two of them. So the first is motor difficulty, which is really a measure of how challenging is the practice, is the motor practice that the child is doing in the session. And so, I think of it as a therapist, I think of it in two ways. So what is the challenge level, but then relative to the child's ability level. So almost like individual challenge level. And it's going to be different for every child, of course. And the second is motor error, which we measure as a count and then a classification of the types of losses of balance during therapy.
Yeah.
So the challenge part, which we often talk about, right? So it's incremental challenge. We say that as an important part of learning a skill.
Yeah, finding that sweet spot, I suppose.
Right, yeah. And usually it's pretty subjective in terms of like, this feels harder, or, you have a feel of it going, it's too challenging, they're not so successful. So how did you go about quantifying that?
Yeah, this was our hardest one to measure. And so, and one that we also, we can't use really novice code. We do all this work is behavioral video coding. So manual video coding of watching the therapy session. So it's pretty intensive and, needs sort of good attention to detail. So most of our coding, we can have undergraduates or post-bac students or physical therapy students. And for this particular one, we've learned that we really need folks who have some sort of movement science or therapy background. So we can use physical therapy students and trained therapists as well, but we can't use undergrads very easily because we have a foundational code for all of this measurement of the content, sort of the ingredients and the dose of intervention is what we're really trying to get at here. And we have a foundational code where we first go through and just mark what is the gross motor activity that the child is doing. And those are mapped to the gross motor function measure. So 10 activity codes there, plus, like a not recorded code, and that helps us just omit that time for future steps. And so we have the foundational pass of activity, and then we have a second pass is the therapist assisting the child or just touching the child, like contact but not assisting, and then is it sort of no contact or independent practice. And so we combine those two to sort of give us the clips that we want to measure for difficulty. So then we look at each activity. So every walking clip, every sitting clip, every transition clip, whatever. And we see if we can map it to one of the GMFM, the gross motor function measure items. If we can, and so that means the level of assistance also has to match the test. So most of them are unassisted that we're measuring.
Yes.
There's a few that the therapist can be assisting. So there's a few sitting items where therapists can be providing support at the trunk for head control measurement. Sure. Some of the one handheld or two handheld in the walking items. So if it matches, then we score it just like we would the GMFM. So the 0, 1, 2, or 3 score.
Yeah.
And so we get the score, we get these items scored throughout the therapy session. We have to combine several therapy sessions together to have sufficient items to get a reliable GMFM score. And then we use that as really our estimated level of difficulty. So this is approximating the child's difficulty level in their gross motor practice.
Yeah, okay.
And not necessarily in other domains, not necessarily their cognitive practice or fine motor practice, but in their gross motor practice in the therapy. These are physical therapy sessions.
Yes.
So they're designed for gross motor practice. And then we subtract that from the child's most recent GMFM, which for the study that I'll present on was within the last 6 weeks. And then we get sort of the delta of that is sort of a normalized or relative measure of individual difficulty. And then we can say, so which children were routinely practicing skills that were harder than their current level of function or at the same level or lower than their current level of function.
Wow.
That's very comprehensive.
That's amazing.
Yeah.
Yeah. Now, you did report on some of the results. Well, you will be presenting some of the results. Can you go through what that looked like? Because that would be incredibly interesting to know what that level of difficulty is.
Yeah. So in the iMove study, we compared 2 groups of participants. They were randomized to what we called iMove therapy, which among other things was intended to facilitate higher level practice or more challenging practice through the use of a body weight support system. And also, since we're talking about the error results, also it was intended to promote more error experience, so greater amounts of error experience in the children, compared to conventional practice, which didn't use the weight support, and in terms of error, facilitated, encouraged the therapist facilitation, more of like sort of perfect practice, so minimizing error was the conventional group.
Yeah.
And so we found that both groups practiced at a higher level during physical therapy than their current level of function. So we know physical therapy can encourage practice of more difficult motor skills.
It's good to know.
Yes, good to know.
Reassuring.
If we didn't find
reassuring.
That, right?
Good.
And then we found that in the iMove group, there was a significantly higher relative challenge in that group, even compared to the conventional. So we learned that we can manipulate this, that rehabilitation therapists can manipulate the challenge level, when they're asked to and when the protocol requires it.
Yes.
So that's really exciting. I think we found the same for motor error, that we can manipulate motor error to the level in terms of losses of balance and falls to a level that approximates what the frequency that we see in typically developing children.
Yeah.
So what our next step is, does it matter? Or what's more important? We think these things are important, but it's going to take some pretty complicated, I think, modeling. The ingredients that we are all measuring are not independent of each other. So if you're practicing harder skills, you're more likely to fall. If you're practicing easier skills, you're less likely to fall.
Yes.
If you're sort of you mentioned sort of that just right challenge. So if we're practicing way too hard skills and the kids are just falling all the time,
it's
that's
really
probably
demotivating,
not,
right?
and that's probably not they're probably not learning how to move from that.
That's right.
So we think there's this optimal level. I hope that we can sort of provide some insight onto what those levels are.
Yeah. I'm really interested in how all that ties into their motivation to practice as well. Like, I'm just thinking, talking about that sweet spot, a lot of it is to do with motivation. And if you're pushing them that little bit too far, too often, it has, a negative impact on practice. But the opposite is true as well. If it's too easy and it's not challenging enough, that can also not promote motivation. These are great points. We don't know the answer to these. I mean, other than, of course, the kids are going to be more motivated if they're having some success. And
that's right.
I think of the flip side of error to be success, and it's not exactly an inverse. Like if we wanted to code instead, like what is the success rate on each task the child is doing, we would have a really different approach.
Yes. Yep.
But I think it speaks to, so we have our therapist, our therapists are supposed to challenge the participants, and they're supposed to encourage error, but they also, as therapists, are supposed to ensure a certain amount of success. And, where those thresholds really are probably different for every kid.
Yeah.
And so it's really hard to define.
And potentially different each day, with the same child on different days, that threshold will be different as well. So it's really challenging.
And the role
we do
of that child's
measure
cognition as well.
All of that. All of that plays in. We do measure motivation to move. I was talking a little bit with Dana about this yesterday. It's a 1 to 5 ordinal scale, so it's not as sensitive as I think our more specific coding approaches. But it does give us, and it's one that we are just learning. It doesn't seem to change, at least at that level of non-precision with the scale that we're using, that 1 to 5 ordinal scale. We're not seeing it change over the course of therapy, even when motor function improves. So we probably need better ways to measure that, like more specific ways to measure motivation to move and in specific tasks versus we're doing it sort of globally for the whole therapy session.
Wow.
Yeah.
So whilst this work is underway and we're trying to quantify both of these factors in terms of the challenge and error, what would your message be to clinicians today providing interventions as they normally would do? We know that we can make these adjustments, but what would your advice be until we can quantify it? Yeah, what would you say?
So my advice would be that, kids with CP, if they could create motor learning opportunities on their own, like their typically developing peers, then we would see them sort of gaining motor skill probably at a rate that's closer to their typically developing peers. So it seems like that we do need to help them in some way, like design their environment or with physical assistance to provide motor learning opportunities. And what we know today, what we know pretty well today, is that higher levels of challenge seem to be related to better outcomes. We know that in typically infants sort of self-scaffold their motor practice to create those opportunities for themselves. We also know it from adult neurorehabilitation that high level of challenge has been shown to improve outcomes. So high level of challenge, but not to the point where it's frustrating, demotivating, and completely unsuccessful for the child. And then in terms of error, I think they go hand in hand. So I think a similar advice around error: give the children time to problem solve. Give them time to make their own mistakes.
That's the biggest challenge for clinicians, isn't it? It's like, no, wait.
They want to rescue.
Let it play out.
And actually, that's one of our codes for losses of balance. When the therapist intervenes and prevents the fall, we call it a rescue. And so, they often have to do that so the child doesn't get hurt or bump their head or something.
You're also kind of overriding human nature, aren't you? Like you just want to jump in and help. And
exactly. But we think that the experience of falls and what we call saves, which is a loss of balance that the child is able to recover from on their own.
Brilliant.
We think that those two are the more important learning experiences. Because if the child loses their balance and is rescued, we're teaching them that they're safe and that's important. But I'm not sure that they're learning, they're not problem solving, what to do next time when they lose their balance.
So we need to evaluate the environment and situation. I fell because I wasn't paying attention, I was doing this and that, not looking at the floor. Like it's kind of, you need to have that opportunity.
Because then if you have I was doing those things, but it didn't matter because someone caught me.
It didn't matter. So there's not that like internal, whether it's conscious or unconscious, sort of like reflection of the motor learning, the motor system.
So, and we've all had that where a child's walking in one direction, you're there for balance, and suddenly they kind of go, and they just sort of fall backward, and you catch them, and you go, okay.
That's right.
How do I find another scenario where they're not doing that?
That's right. Keep them working, keep them paying attention.
And in actual fact, I just think the work of the therapist in these kind of roles, you're constantly thinking 5 steps ahead of how you can make that challenge or what you can keep them motivated with. Otherwise, I think we can play too much of a role in directing too much of it. And it's so easy.
It's so easy. Well, that's what we're taught to do, is have a directed therapy session.
Yeah.
So one of the other variables we measure is child initiation. And so we take each of those foundational gross motor codes, and then we say who initiated this activity. Was it the therapist or the child? This movement. Was it the therapist or the child? And then we found that sometimes so the classic example is a pull to stand. Maybe the child wants to reach something on a high bench or treatment table. So they want to pull to stand, but the therapist intervenes to just for the motor pattern, right? So the child wants to stand, but let's dissociate the legs, and so let's facilitate a half kneel. And so then we developed a second code to be able to say, okay, who initiated the whole idea to move, and then who initiated like the motor pattern?
Interfered,
or maybe the child, wants to crawl across the room, and the therapist says, let's go get that, but we're going to walk.
I'd love to see your coding. That would be so interesting. Like, we need another code for this.
That's right. Because maybe, that's maybe important. The therapist wasn't doing nothing, but they weren't letting the child just practice in their own comfortable way. So
can I put you told me the story about your bub.
Oh, yes.
And can you tell that story? Because it's kind of really cool.
I can, yes. So I've got a little 6-month-old who has now mastered the skill of rolling over, but was trying to roll onto her belly for some time. She's got 2 big sisters, and the big sisters were very keen to help her roll over. So oftentimes she'd be, initiating the movement, but then one of them would just come and flip her over onto her belly.
Like sideline struggle.
And they just come in, plop her over, and I had to sit them down and say, whose brain is doing the work? And my 5-year-old kind of got it. My 3-year-old didn't. But I'm like, if you move her, her brain's not doing the learning, your brain's doing the learning, and you already know how to roll over. And she was like, oh, okay.
Yeah, what a great lesson. That's a great story. Yes.
I feel like that's the therapy journey in general. It's just constantly thinking about that. And I think your work really puts a spotlight on that. And I love that you've gone that extra mile to actually quantify that, because without it, it's all a little bit subjective.
Yeah, it's so subjective, and as a therapist, I have always, when I started, but how much, and like, what does this mean? And okay, it's great to say we need to promote challenge and we need to self-initiate, but some of those things, they're sometimes contradictory to each other too. And so we want independent motor practice, but we want the child to be initiating. And so there's some children who, if the therapist doesn't put their hands on, the child will lay down the entire time. And so how do therapists reconcile those competing priorities is really hard. So I hope we can start to give therapists some guidance on those
and
priorities.
Once you do that, then it's health equity again. It's something that we can teach to so many people, right? Right. Well, I feel like I could talk to you for a long time. I say that to everyone, but we should wrap up.
We should. Thank you so much for coming and joining us, Laura.
You're welcome. Thanks for having me.
Enjoy the rest of the conference.
I will. Thanks.
Thank you. To all those listening, I hope you really enjoyed that as much as we clearly did. And we'll talk to you all again really soon. Bye.
Bye.